Good afternoon, Senator Kane. Good afternoon, Senator Wagner. I'm Tanya Creque, a registered nurse and a nurse educator. My team of fellow nurses, Nicole Appleholm, Angela Fleetwood, Paige Krenisky, and Amy Reilly-Torres, have asked me to represent our group today in presenting to you our policy proposal. Mental illness is prevalent in all communities across America. Community leaders know it, legislators know it, and families certainly know it. Our policymakers, such as yourselves, have been proactive in addressing some of these issues by passing the Helping Families in Mental Crisis Act of 2016. Mental illness, as I mentioned, is very prevalent. 1 in 5 adults in the United States, approximately 44 million Americans, experience mental illnesses in a given year. 9.8 million experience a serious mental illness that interferes with or limits their major life activities. Among the 20 million or so adults in the US with substance use disorders, half of those have a co-occurring mental illness, according to National Association of Mental Illness. Jails and prisons hold more mentally ill individuals than the largest remaining state psychiatric hospital, according to Treatment Advocacy Center. In every county in the US, with both a county jail and a county psychiatric facility, more seriously ill individuals are incarcerated than hospitalized. Those with mental illness remain incarcerated longer than their counterparts without mental illness, according to NAMI. That equates to 1.2 million Americans living with mental illness in the penal system each year. 15% are men, 30% are women, according to Mental Health America. However, once in jail, most individuals don't receive the treatment that they need, and they actually end up getting worse. Some extreme mental illness cases that may come to your mind: Jeffrey Dahmer, for example, was the Milwaukee cannibal; Ted Bundy, Charles Manson. All of these individuals suffered from mental illnesses, and they were incarcerated. Now, whether or not they were treated appropriately is anybody's guess. The Helping Families in Mental Crisis Act focuses on strengthening the federal role in advancing mental health, authorizing programs to advance screening and early intervention, especially for children, promoting both evidence-based initiatives and innovations needed to address mental health concerns, and encourages the involvement of families in providing support to their family members while maintaining their privacy. Mental Health America goes on to say that this initiative prioritizes community-based services and plans for a reduction in incarceration, which means less homelessness as well, while ensuring that those individuals have employment. It also speaks to supporting more meaningful guidance and oversight, preserving SAMHSA and its programs while adding funding for additional mental health services, and then growing the behavioral health workforce. We need those individuals that are plagued with mental illness themselves to be a part of the care and support of those that are incarcerated, promoting their recovery. Well, Rangel, Gonzalez, and Connell in 2014 conducted a study on the screening and medication continuity of mental illness in the US prison system. The study yielded 50% of 18,000 mentally ill inmates were medicated at admission, but did not continue to receive medication therapy during their prison term. Now, I quote, "Inmates with schizophrenia were most likely to receive pharmacotherapy compared with those presenting with less overt conditions," end quote. Now, basically that means that if someone came in and they had bipolar disorder or maybe depression or other types of mental illnesses, they were not treated. Well, that doesn't seem right. So our proposed policy change is to provide qualified psychiatric staffing, to implement screening programs for all inmates, and to increase funding. Let's look at those a little bit more in detail. In regards to qualified psychiatric staffing, the inmate population increases nearly 4% annually, but there's no increase in the psychiatric staff in correlation to take care of these individuals. Well, lack of treatment continuity is partially due to the increase in inmates and the lack of increase in staff, according to Rangel, Gonzalez, and Connell. So that results in lack of properly medicating inmates. They're not being diagnosed properly. They're not being treated properly. This leads to increased outbursts and aberrant behaviors while they're in jail. We know that with proper diagnosis, treatment, and management by psychiatric professionals, be they doctors, nurses, or lay individuals, it'll decrease criminal activity in prison, and post-release. In regards to our proposal for screening programs for all inmates, we want to standardize mental health screenings for all new and returning inmates. Now, there are some evidence-based screening tools that are currently being used, but they're not being used in the manner in which they should. And again, it's not a standard practice across the board. So what we're proposing is for every new inmate that comes into the jail system, they would be screened using one of these tools in order to ensure that we're able to diagnose what mental illnesses they may have and concurrently initiate treatment sooner. The same is true for those individuals that may be returning to the jail system. They need to be reevaluated. We don't know if they complied with their treatment program when they went back into the community. So we need to reevaluate them again using those tools in order to identify any changes if necessary and initiating the treatment that would be most appropriate for them. Increase in funding. Well, according to Wallace, there's a link between mental illness and incarceration. We definitely know that already. Well, according to Vera, in 2015, 45 states were asked to respond to an inquiry in regards to expenditure for taking care of inmates. Well, the total state expenditure for inmates was approximately $43 billion. Hey, that's a lot of money. The average cost of care per inmate is $33,000, just a little over $33,000. Now imagine if one inmate bounced in and out of the system 2 or 3 times in the course of a year, that could be anywhere between $66,000 and $100,000 just on that one individual. Well, we feel like there should be an audit of how those monies are being spent that are allocated for incarceration, because there seems to be a huge disparity between how much it costs to take care of them and the total expenditure. So some of that budget, those budget dollars, we feel like could be shifted, could be reallocated to fund the programs that we're talking about. And additional financing options, grants from states or local agencies or mental health consortiums would be an additional way that we can ensure that we reallocate those funds to employ psychiatric professionals to properly diagnose, treat, and manage those mentally ill inmates. Again, at the end of the day, we want to decrease the number of people going into the prisons and the jails, which ultimately is going to decrease the expenditure for inmates. So to summarize, we want to make mental health programs available within the jail system. We want to increase availability of qualified psychiatric staff. We want to increase fund allocation to finance the proposed changes, which ultimately is going to decrease the number of prisoners, thereby decreasing state expenditures. So what are the outcomes? Well, alternative one would be if the policy is not changed, then the outcome would be the same. We have untreated individuals who are mentally ill that are going in and out of the prison system, kind of the revolving door, continuing to add to the criminal acts in our communities. Alternative two is change to the policy, but lack of engagement. That means the policy has been approved. We try to put systems into place, but people just aren't buying in. So if that's the case, the outcome would be the same as if the policy had not been changed in the first place. But we're looking for alternative three, change to the policy and engagement. The policy change is embraced, programs are implemented, which would lead to an increased awareness of mental illness, not only in the jail system, but in the communities, increase of funding, and increase in resources for the inmates during their prison term and post-release. Mental Health America 2018 states, and I quote, "People should receive appropriate supports while incarcerated and have a plan that connects them to community-based services within adequate coverage prior to returning to the community," end quote. That's exactly what we're looking for. Our plan would ensure that our goal is met, which is to ensure the best outcomes for mentally ill individuals. This includes keeping them out of jail and reducing reentry. Our plan is essential to creating the systems that support individuals as they transition in and out of incarceration. We want to assure appropriate support and resources are available while the inmate is in jail, as well as treatment plans that connect them to community-based services prior to them returning to the community. NAMI says that's a great idea as well. Ultimately, these options, these interventions would decrease the likelihood of regressive behaviors or undesired side effects from lack of treatment. So what are the advantages of the policy change being implemented? Well, we feel like investing in mental health and substance use services for all people will reduce the likelihood that those individuals will face incarceration or reincarceration. Providing mental health treatment programs already has strong evidence for reducing days of incarceration, so we're looking at doing exactly the same. With post release mental health programs, former inmates will have access to treatment modalities, which include medication management, counseling services, job training skills, things that actually will get them back on track so that they could be viable members of our communities again. Without these resources, however, inmates typically fall back into the same pre incarceration behaviors and activities that ended them in jail in the first place, according to Mental Health America. Disadvantages, there are advantages and disadvantages to everything. The disadvantages, our policy change, of course, the advantage of our policy change is to increase services and access to those services. However, everyone may not want to take advantage of those services. So those individuals that are non-compliant with prescribed therapies will, of course, continue to suffer with their own illnesses, which will, unfortunately, continue to perpetuate the actions that led to their incarceration in the first place. This is a never-ending cycle of homelessness, lack of health care, increased criminal activity, even loss of dignity as a result. So, policies are always very expensive. We're looking at what is the policy change cost? Is it feasible to introduce that now and in the future? Well, in 2013, non-institutionalized spending on mental illness cost $89 billion, according to the Bureau of Economic Analysis Healthcare Satellite Account. 89 billion. That tells me that funds are available. The Helping Families in Mental Health Crisis Act of 2016 actually allows for state Medicaid plans to pay for mental health services. The Mentally Ill Offender Treatment and Crime Reduction Act by the Council of State Governments in 2018 says that there's funding available via the criminal justice system. Those funds are available for mental health and addiction treatments for those individuals who are either incarcerated or re-entering the community. This act provides law enforcement training to help those officers identify individuals and respond to those individuals who have mental illnesses. That's very important. Oftentimes, they come upon individuals that have aberrant behaviors that are involved in criminal activities, and they just don't quite know. Well, currently, this act has assisted in funding many health courts, supported various local police departments in order to get the training out there on the streets so that citizens that do not have mental illness, or maybe more importantly, those that do, are treated appropriately. Now, the price index for mental illness treatment has grown at a very slow rate, an annual growth rate of 3.1% from 2000 to 2012. Now, in comparison, on average to other disease categories, which grew at a rate of 4.4%. So what does that tell me is that adaptation to policy changes are very slow. So what we need to do is we need to ensure that our policies are embraced, that engagement does occur, and that change is imminent. So what's the process for evaluating the change? Well, the assertive community treatment and multisystemic therapy helps to allocate, to document the number of days that an individual is incarcerated in comparison to the number of days that they're in a community. Well, now, why is this important? Well, because if our policy is saying that if we have better treatment modalities while they're incarcerated, if we have transition programs for their post-incarceration period, then we're hoping that it will decrease the amount of time that that one individual is going back into jail. And that will definitely impact that $33,274 amount that it costs to take care of that individual every time they go in. So that is a savings. Incarceration rates should be reduced if those individuals are identified and treatment is provided appropriately. After all, that's what it's all about. We do know that as of 2017, Arkansas, Mississippi, and Alabama have the least amount of access to care and have the highest imprisonment rate, according to Mental Health America. That's very sad. It's very challenging also. So who do we have that's supporting our policy already? Well, locally, the Virginia Nurses Association supports our initiative. Senator Kane, thank you very much. He supports our initiative as well, especially after that mass shooting in 2007 at Virginia Tech. Senator Kane signed a $42 million legislation to overhaul the state's mental health system. We know that there are individuals that are currently outside of the penal system that, for whatever reason, end up incarcerated that need treatment. So these policies that we're talking about really will help to identify those individuals and get them the treatment that they so desperately need, but they're not able to receive anyplace else. We also want to approach mental health associations and local interest groups, as well as additional governmental agencies that may have strong tie to the community agenda. You know, sometimes it really only takes one individual that has a loved one, a family member who has been plagued with mental illness, who really takes on the challenge of wanting to see a change in the process. According to Mason Gardner Outlaw and O'Grady, in this information age, nurses must proactively use media to influence policy and make themselves available to speak with journalists about policy matters. Well, media, television, radio, social media, all of those will be aspects not only to enlighten and to create awareness about the concern, the problem, but also the policy. It's very important to garner supporters in our profession as nurses, in the medical profession as a whole, as physicians and other caretakers, but also to get those on board who live and work in our communities to ensure that they're supporting for better change as well. In closing, to encapsulate the proposed amendment of 2646 that was enacted in 2016, we want to propose to increase funding or to reallocate funds to include treatment programs for those individuals that are incarcerated and have a diagnosis of mental illness. We want treatment to include pharmacotherapy, counseling, awareness agendas throughout their period of incarceration and post-release. We want to introduce and effect change in educational training programs for law enforcement and corrections officers. This will increase their awareness in regards to recognizing the signs of mental illness in those individuals that have not gotten to jail, or for those that are post-incarcerated, and how to approach those subjects. Treatment of incarcerated persons with mental illness needs to continue post-release. We have to have those transition programs and processes in place so that their treatment, whatever they may have started in jail, can effectively continue once they get back to the community. Considering nearly 45% of those individuals incarcerated have a mental illness diagnosis, continued support post-release and reduction of reentry will provide cost-saving measures to local agencies, government programs, including the penal system. Thank you so much, Senator Kane, Senator Wagner, for your time this afternoon. We hope that you will continue to support our proposal.